the aim of today's section. So overview of the cornea. So the cornea is the transparent outer layer of the eye. So I just had like 3 diagrams here. So when you look at the eye, the very outer bit that you see, the little dome, is your cornea, basically. And the cornea performs 2 functions, so protection and refraction, but it's a clear, transparent outer layer of the eye. So one of the basic functions is the protection bit of things. So it serves as a barrier against dirt, germs, and other things from entering the eye. And one of the basic functions, which is quite important, is refraction. But I'm not going to make it complicated. I'm sure that our optometrists and student optometrists understand what refraction is. But basically, it focuses light into the eye. And this stems from how our vision works generally. So when we look at an object, light from that object is focused into the eye through the cornea, through the pupil, and then it hits the retina. And when it hits the retina, it goes to the optic nerve head. So the optic nerve head converts this to electrical signal. And once this signal is converted, it hits the brain, and the brain interprets this image. So basically, this happens in quite a very quick split second. So it's important that the cornea is quite healthy. So basically, that's that function it performs, and it's quite a major function when it comes to sight. So I'll just read through my notes. So this, hence, when light from objects enters the eye, it's bent by the cornea curved edge, and this determines how well your eyes can focus. So if there's any infection, disease, or injury that results in a scar on your cornea, then the information that it sends to the brain is distorted, and then the feedback is not always quite good. So you may get a blurry image and things like that. So that's just that in a nutshell. So that picture there is just like when you're looking at a tree and light moves into your eye through your cornea, and then just what I described. So basically, that's one of the major functions of your cornea, and that's why it's important for the cornea to be healthy. And then the cornea have got some key characteristics, and one of it is avascular. So when I say avascular, it means that it's not got any vessels on it. Reason being why that it's very important for the cornea to be as clear and transparent as it can. So because of that, if it's got any vessels on it, it's an abnormality, because it will make things not, information not transfer clearly to the brain, more or less. So if the cornea has blood vessel, it may cloud the cornea and prevent it from refracting light properly, and may adversely affect vision. So because of its avascular nature, nutrients is supplied to the eye, more or less, or to the cornea through the tear film anteriorly, and then posteriorly through the aqueous humor, more or less. But we'll discuss a bit more of that when we go to the layers of the cornea. And then the cornea also is densely innervated, which means that it's got loads of nerves on it, and it's supplied by the trigeminal nerve. But I'm not going into the complicated details, but this is very important for when your patient comes in. And if the patient comes in with a complaint of red eye, one of the things you want to find out if it's related to the cornea is when they are coming in with pain, and then photophobia and reflex lacrimation. When I say photophobia, it just simply means sensitivity to light. So when this happens, it kind of rings your bell. It may be the cornea, because it's got loads of nerve on it. Just for fun, the average corneal diameter is 11.5 millimeter vertically and 12 millimeter horizontally. Then the cornea also is estimated to be approximately between 540 to 550 microns thick centrally on the average, and thicker towards the periphery. So you can imagine that our conversation is more like interlinked, because Ahmed has covered this. So it's very, very, very important, as he mentioned earlier on, with regards to your intraocular pressure. So I'm not going to dive into that, because he's already said everything that needs to be said on that. Layers of the cornea. So basically, I'm just going through these layers just so that you understand when there is a corneal disease or anything happening on the cornea, you understand which part of the eye it's happening in and how the eye reacts to that, or the functionality that is being impaired. So the outer bits, as you can see here, we've got the epithelium. And then we've got the Bowman, which is very, very tiny, but it kind of protects the stroma. And then if you pay close attention, we've got the stroma, which is the bulk of the thickness of your cornea. And after that, we've got this tiny layer, which is your descent layer. And then obviously you've got the endothelium, which is in contact with the anterior chamber. Obviously, when we're in school, we usually say the A, B, C, D, E of the cornea. It helps you remember the layers of the cornea for some of our students that may want to memorize that. So if we go to the cornea epithelium, so the cornea epithelium is the outer part of the cornea, and then basically it provides the outer surface for your tear film to relax on, more or less, and that provides protection for your eyes, more or less, because you blink and then it generates like tears, and then it helps with refraction as well. So it provides the optimal surface for the tear film to spread across the surface of the eyes, hence keeping it moist, healthy, and maintaining clear and stable vision. And then it absorbs oxygen and nutrients from tears and converts it to the rest of the cornea. Then epithelial cells are constantly produced and shed into the tear film layer, and the turnover for the entire corneal epithelium is about a week. So any injury on the epithelium of the cornea is easy to heal because it regenerates quite quicker. It's got a lot of nerves on it as well, so which means that you could have pains when you have scratch on your epithelium. The Bowman layer is, like I said, is the one that prevents things from harming the stroma. So basically, it's just an interlink between the epithelium and the stroma layer. Just because of its dense nature, it prevents corneal scratches from penetrating the stroma. So it's more like a protective layer. The stroma, like I showed us earlier on, is the thickest part of the cornea. So it contributes 90% of the corneal thickness, and it's very important for it to remain in the way it's been arranged, more or less, because that spacing and the arrangement prevents, helps with optical clarity, and then gives stability and thickness for the cornea in itself. So anything that harms or destabilizes that is going to make us have like vision not being so clear, more or less. And then if we go to the next one, your descent membrane. So basically it's a thin layer that separates the stroma from the underlying endothelium layer. It thickens throughout life and has a regenerative potential. So it's more like a link than any other thing, really. Then the endothelium is a very important part of the cornea. So it's made up of a single layer of polygonal cells, posteriorly battered in clear aqueous humor. But basically what it does is that it maintains corneal clarity and transparency by removing excess fluid from the stroma. So it's known as deturgescence. What it does is that it dehydrates the stroma, and then by doing that, it makes for optical clarity. So which means that if any injury or any disease or anything that affects the endothelium, what happens is that the eye tends to retain fluid, which means that you're going to end up with edema, more or less. So that's why anything that affects this layer is quite not good for your vision, really. And you may be looking at corneal transplant and all that. So I think that's the basic on the layers of the cornea. I just tried to rattle through that because it can be boring, but here we go. So we'll go straight to the introduction to corneal diseases. So basically, from the name, you will know that corneal diseases are just conditions that affect the cornea. So it could be infectious, it could be non-infectious, it could be degenerative, or it could just be hereditary disorders. It could be, some of the infections could be from bacteria, fungi, virus, protozoans, and then we have inflammatory risk factors as well. So when you hear about keratitis, it's just a way of describing an inflammation of the cornea. And some of the things that lead to this could be contact lens wear, ocular surface disease, lid disease, or immunosuppression. So these are the things that could lead to keratitis. Corneal clarity is threatened by neovascularization, like I said earlier on. If there's any vessels growing on the cornea, then it's not good because the image it will send to the retina, which the retina will send to the brain, is not going to be the best of images. And then inflammatory reactions and limbo deficiencies are one of the things that could also affect corneal clarity. So the ultimate goal in management and treatment of corneal disease is to employ minimally invasive procedure that can restore or preserve vision, and because of how sensitive the cornea is and how important its job is to the human sight and vision. Most times we overlook this part of the eye in practice, but it's very, very important. As a man mentioned earlier on, it's one of the causes of low vision as well worldwide. And then before I dive into the different, I'm just going to treat 3 corneal disease today and 3 general ocular emergency, and we are going to all participate in that. But for this cornea, it's very important that you use your slit lamp as an eye care specialist. Slit lamp is quite important for any diagnosis, and most diagnoses you will do on your cornea. Your fluorescein dye is very, 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 very important because it's going to do make some stains on the cornea, which will help you identify some eye pathologies that affect the cornea. And then your cobalt blue filter, obviously, is what you will also use to make your view. So these 3 factors are quite important amongst every other thing that you do when your patient comes with any corneal problems. So I'm just going to go for our first poll, which is our case 1. So this is a 48-year-old male. He presented with redness in the right eye, blurriness, photophobia, and a feeling of sand in his right eye. Generally, he feels healthy. He's not on any medications. Ocular health history, non-visual acuities is 6.9 and 6 and N6 and N5 for close-up, and he doesn't wear any contact lenses at all. Sean, I don't know if you want to bring up the first poll. If we can just choose what we think the answer is for that particular presentation. Amazing. That's quite good. Well done, everyone. That's a good diagnosis. So if we go to the next page. So basically, that's herpes simplex keratitis, also known as the epithelial keratitis. So when we talk about the herpes simplex, it's caused by a virus. It's the herpes simplex virus that causes the herpes simplex keratitis. And we've got 2 of it. We have the HSV1 and the HSV2. The HSV1 affects the part of the body above the waistline. So that's your face, your eyes, your lips. And the HSV2, sorry, affects the lower bit, which is obviously where you get your sexually transmitted disease and all that. But we're interested in the HSV1, basically. So most humans have this in a very dormant stage, not active. So 90 to 99% of us have it, but it's not dormant. But when we are stressed due to probably fever or hormonal changes or different factors, it could activate it and then send it up to the body, and then this can affect your eyes and turn up as these symptoms in keratitis, more or less. So like I said earlier on, your slit lamp examination is key, and you need to instill your fluorescein, and when you do that, you have your classic dendritic ulcer. So that's the classic sign that tells you that this is a sign of herpes simplex keratitis. And what you need to do is to refer your patient urgently to get some treatment. I know that some of us, obviously in Nigeria, can manage these patients, but we try to discourage the use of steroids on these patients because it can lead to geographic ulcer. More or less, it makes the dendritic ulcer a bit more wider. So you want to avoid using steroids. Instead, you can treat with eye ointments like the aciclovir or the aciclovir and oral antiviral drug. Case 2, we've got the 40-year-old female presented to the clinic, severe pain, grade 8, photophobia, foreign body sensation, blurry vision, grade 4 conjunctival redness, no discharge, ongoing for a week or more, patient not sure. General health, good, no medication, patient is not diabetic, no cholesterol problem, no high blood pressure, and visual acuities at presentation is 6.12 and 6.9 with, you can see the prescription of the patient and patient is a soft contact lens wearer. What do we think this answer is, or this diagnosis is? Sean, if you put it up. Ooh, amazing. That's good. So basically, that's your acanthamoeba keratitis, more or less. So basically, you need to have a thorough case history and documentation for this patient, because it's very important. It can easily be missed, this particular one. So you need to find out if they are contact lens wearer. It's more common in soft contact lens wearers. This particular keratitis is due to, like if you swim in your contact lenses in a river, or if you use water on them, or if you sleep on them and things like that. It's not very common, but it's quite very drastic. Thorough case history is very important. You need to also grade your pain. So usually we normally look at grade 1 to 10, where 1 is very mild and 10 excruciating. So the pain for this keratitis is quite exaggerated. So when the patient says the pain is excruciating, then you should start thinking of acanthamoeba keratitis. When your redness is about grade 4, so some of us have different grading scale, but grade 4 is more like quite red. You're thinking of that, and then your slit lamp comes in quite handy, because when you do the stain, you can see the classic ring stain. So it's ringing your bell that you need to refer this patient urgently. And then for continuity of care, if we do proper documentation, when the patient comes for follow-up, it's easy to know where their pain threshold is and where the redness is, and that works out well for patient care. Treatment-wise, if you refer your patients, usually the doctor or the ophthalmologist will normally take samples from the cornea and then their contact lens cases to test. It's usually stubborn to manage this particular keratitis, and most times it could end with blindness, painful blindness actually. So it's good that we pick it up. It's better we refer and then it's not really what it is than we don't, and then the patient ends up blind, more or less. So that's quite important. I'll skip that to something else now. Case 3, 15-year-old male presented to the clinic with reduced vision, right eye worse than left. Prescription has changed, itching, and then general health, suffers from allergies and eczema. Medicine, he's on cetirizine for allergy and cream for eczema, and that's what his prescription is like. Next poll, what do we think this presentation is? All right. Okay, so I lost some people to that. So that's fine, great. So basically that's keratoconus, more or less. So this patient is probably going to be having frequent changes in prescription. And then because he's got this eczema and allergy, he will tend to itch a bit more, which means that his cornea will thin down a lot more. So keratoconus basically is more like the eye being, the cornea being progressively changing shape to more conical shape. And this is due to the stroma, which we discussed earlier on, becoming more thinner. And it's quite important, like I said, for optical clarity, for the stroma to be in the right positions with regards to its structure. So anything that disrupts that is going to not play out well. So with regards to keratoconus, so it becomes more conical, the cornea, and then that kind of affects vision. So we need to investigate symptoms. It's very important, especially between the age of 10 to 25, which is the age of presentation most of the time. We need to just make sure that we check for oil droplet reflex. So how do we check for this? So if you move about 30 centimeters with your ophthalmoscope and you look into the eye of your patient, you may notice the oil droplets reflex. 2, when you look at on your slit lamp, you ask your patient to look down and you lift the lids up. You can see the bulging of the lower lids on down gaze. So that's your Monson sign. And we've got the Fletcher's ring as well, which is iron deposit on the epithelium. So you will normally notice that on your slit lamp. And then same thing with the box striae. So these are some of the things you want to look out for when your patient presents with keratoconus or signs or symptoms of keratoconus. And once you figure this out, you need to refer the patient as soon as possible. As much as we may want to monitor this patient or manage them with glasses, it's important that they start being managed with RGP lenses and more than when they get to the point where they now need interventions like corneal transplant or corneal collagen cross-linking, because some people can't afford it, especially in West Africa. Some people may not be able to afford these things. And then because of we can't get corneal donors as well, it could be a challenge as well. So these patients may end up with blindness, which could have been avoided. So on first hand, once you look at this patient and you notice this, I think sending it to someone who is professionally trained to manage this situation or the keratoconus is quite important. I'm sure I'm beginning to run out of time, so I'll just run through the rest of the slide. So this 70-year-old female presented with bitemporal headaches, occasional vomiting, blurred vision on and off, ongoing for 5 days, general health, feeling unwell, not on any medication, and doesn't wear glasses at the moment, and vision is like 6.6. What do we think is this presentation? Amazing. Right answer, papilledema, and it's an emergency referral, more or less. I'll just close that. Okay. So papilledema is more or less an emergency referral for this patient. So it's a medical emergency, is an optical emergency, whichever way you want to look at it. You need to refer the patient ASAP, because most of the time there is an underlying condition that is presenting with these features, and once that is treated or diagnosed, then things goes back to normal. It's very important for you to do your fundus, either pictures or ophthalmoscope or using your Vogue. So you have to use one of the equipments that you use in viewing the back of the eye to actually literally look at the back of the eye. Do not ever dismiss these symptoms. We could just overlook it and look at it, or go and check for typhoid or malaria or something, and you don't look at the back of the eye. It's very important that you dilate the eye and have a good look, because it could be something more serious, which obviously could be papilledema. And once you notice this, don't try to manage, refer this patient as soon as you can. Then the next one, 64-year-old male presented with recent onset flashes of light and floaters, noted 4 days ago on the right eye, noted shadow superiorly in vision, left eye okay, general health, type 2 diabetic for 10 years, high blood pressure and cholesterol. We can see the medications, and yeah, what do we think? We've got inferior visual field defects. What's our take? What do we think is wrong with this patient? The poll. Amazing. So you're correct. So it's retinal detachment. So like I said before, documentation of all presenting symptoms, thorough eye examination with putting drops in to have a good look at the back of the eye. And then with this particular patient, it's very important for you to refer them same day, especially if their macula is still on. So how do you know if the macula is still on? You have to check if their central vision is still okay. So if visual acuity is still okay and they can read okay, central vision okay, tells you that the macula is still in place. So you can actually recover any vision or part of the eye that has been lost, any visual field loss and things like that can be recovered. But the earlier you refer, the better. Usually with treatment, it's usually vitrectomy. So basically the vitreous is removed and then gas bubble put in place to support the retina. And then usually when this gas bubble over time is reabsorbed and then the vitreous chamber is now filled up with normal body fluid and then things go back to normal. But if we delay referral, then obviously things can go worse than we would love it to. The last one, I'll have to avoid the next slide. So 50-year-old male presented with grade 8 to 9 pain, nausea, vomiting, halos around light for a few weeks, plus blurry vision, general health good, no medication, ocular health history none, and then this is what his vision is like with his prescription. And Van Herrick's is grade 1 and with a fixed dilated pupil. What do we think the answer is for that? Amazing. I guess Ahmed presentation gave us a clue on that. And so that's an ocular emergency. You need to refer ASAP, document all presenting symptoms, and check your intraocular pressure, slit lamp examination, fundus exams, and visual field defect tests to find out if there's any defect or not. And then as well, you want to refer them same day and don't wait for the next day. No excuses, refer patients same day that they presented with that. Ahmed said something about your Van Herrick, so it comes very handy. You need to check that as well because that will give you an information on what's going on. And then I think that's me done today. Thank you for your time.